Okay, great. Again, good morning. My name is Adrian Dominguez. I'm an epidemiologist and the Chief Data Officer for Seattle Indian Health Board, Urban Indian Health Institute. And it's an honor for me to be presenting on Indigenous data sovereignty in Indian country today. I want to thank the United South and Eastern Tribes for inviting me to speak at their conference. A little about who I am. I oversee our internal and external, local, various state and national data sets, data systems, infrastructures, data infographics, data dashboards, or data analysis, epidemiology, surveillance, and methods for our surveillance and research activities at SIHB and Urban Indian Health Institute. I'm really excited about presenting on today's topic, the importance of this topic, and why it is necessary for us to reclaim and govern our data and to take ownership, manage, and oversee the application of its use. Without doing this, we will continue to see the misuse of data on American Indian Alaska Native population. We continue to see the data being interpreted incorrectly and used against us. We will continue to see wrong conclusions being drawn that perpetuate and sustain biases and stereotypes of our populations. We must insist on Indigenous data sovereignty practices. If not, mainstream will fail to recognize our strength and resiliency, and more importantly, will fail to recognize us as a relevant population. We need to make sure we receive the monies and resources needed to address the disparities and inequities that exist and impact our mental, physical, emotional, and spiritual health and well-being within our communities. Before we get started, I would like to review the topics of what we will be discussing today. We will begin with an introduction of Indigenous data sovereignty and what it means. I would then like to talk to you about the history of data and how it has been used in the genocide of American Indian Alaska Native population and how it continues to be practiced today. Then we will talk about decolonizing data and its principles and framework. Next, we will talk about American Indian Alaska Native data challenges and gaps with collecting and analyzing data. We will then discuss data misclassification and the impacts this has on Indigenous populations. We will then end with recommendations and best practices for data collection and analysis on American Indian Alaska Native populations. So now let's talk about Indigenous data sovereignty. What is it? Data sovereignty is the right to govern the collection, ownership, and application of one's own data. Our work at the Urban Indian Health Institute is grounded in the principles of Indigenous data sovereignty. In order to conduct Indigenous epidemiology and evaluation, in order to give the very best to our communities, we must honor and uphold tribes and American Indian Alaska Native urban communities' inherent right to govern their people's lands, resources, and data. This individual and collective right to reclaim both external data collected on Native communities and to create data that is for Indigenous people by Indigenous people is fundamental to any effort that addresses inequity among American Indian Alaskan Natives compared to populations with more resources and opportunities. American Indian Alaskan Native communities experience some of the starkest disparities in health outcomes, which are a result of an ongoing racism, prejudices, and biases, inequitable and insufficient distribution of resources, and programs and policies that do not reflect Indigenous needs, priorities, or self-conceptions, all of which stem from a history of colonialism, including removal from land and forced loss of language, elimination of culture, forced assimilation, and genocide against Indigenous peoples. In order for us to do our work as Indigenous people, we have to look at the history of data and how it was weaponized as a tool to subjugate, assimilate, discriminate, and eliminate our people, Indigenous people. The small population of American Indian Alaska Natives didn't just happen. It didn't happen by chance. It's not coincidental. This was intentionally done by the US government. We must understand and never forget the United States' need to remove and eliminate American Indian Alaska Natives from our land. There were efforts to eradicate the population because we were not worthy to remain on this land. Colonists, settlers knew what was best, and we were not part of that plan. So let me be frank. We are told too often we cannot do any analysis of American Indian Alaska Native population because it's a small population and there is not enough data. We often see we are not included in reports. We are omitted. Well, I'm here to say this. A fundamental step to conducting small population research is the understanding and acknowledgement that this population isn't by chance, as I have stated. Therefore, it is vital, critical, and essential that we as Indigenous people exercise the right to govern, collect, and oversee the application of any data that pertains to us. This is Indigenous data sovereignty. There's a long history of public health and public policy that has systematically and continually undermined and destroyed the health and well-being of Native communities. I would like to share some examples of how the United States government and researchers attempted to mistreat, abuse, and harm Indigenous people in an attempt to eliminate an entire race. In 1763, British General Geoffrey Amherst deliberately gave blankets infected with smallpox to Native Americans in order to eradicate them. He considered them to be deplorable and disgusting. As a result of this biological warfare, many Native American tribes experienced a depopulation, averaging 25 to 50% loss in population. In the late 1800s, the Gila River, which was the central source and farming irrigation used by Pima Indians, was cut off and rerouted to farmers upstream. The loss of water resulted in the community being cut off from their traditional food practices and ultimately starvation and poverty of the Pima. Pima had to rely on government rations, commodity program, which consisted of white flour, lard, canned meats, and other sugary processed foods, and resulted in an obesity epidemic and some of the highest rates of diabetes in the world. It was the express policy of the US government to sterilize Native American women throughout the 1960s and 1970s, oftentimes without informed consent or through coercion that threatened the denial of welfare and social service benefits if the woman would not acquiesce. It is estimated that by the mid-1970s, more than a quarter of all Native American women between the ages of 18 to 44 reproductive age had been sterilized. This coordinated policy of the federal government was designed to limit the reproductive capacity of Native communities. Now looking at research. In Alaska in the 1970s, a study of the alcohol was conducted on the Native tribes 15 and older. The hope was to assess the role of alcohol use in traumatic deaths to facilitate the design of beneficial interventions. Among the issues with this study, proper consent was not obtained. Resulting report did not accurately reflect attitudes and values of the community. It was also noted that only natives were studied. Outsiders in the town were not included, and before consulting with the community, the sensational findings were leaked to major news sources. In the early 2000s, there was a study conducted with the Havasupai tribe that collected DNA to study type 2 diabetes, but the samples were then used for schizophrenia research and geographical mapping, which was not included in the consent process or stated research goals. This also reflected negatively on the tribal community. This is another present-day example of the maltreatment and disrespect for Native sovereignty. These are just a few examples, but there are many more. So what does Indigenous data sovereignty look like in our organization, UIHI? How do we do this at our organization? So when we talk about data sovereignty, we need to understand that achieving data sovereignty requires us to decolonize data. So what does decolonize data mean? It means we are talking about reclaiming the Indigenous values of data collection, data analysis, and research, both qualitative and quantitative research. We are talking about data for Native people, by Native people, and recognizing the inherent strengths of Indigenous people. Decolonizing data encompasses Indigenous methodologies, Indigenous epidemiology, Indigenous research, and cultural rigor. At UIHI, we're initiating the shift into decolonizing data by introducing culturally rigorous science, reclaiming Indigenous values, and using our knowledge to bring health back into Indian population and communities. We practice, and at the core of our work, our framework, are the principles for decolonizing data. They include Indigenous epidemiologies, Indigenous methodologies, Indigenous research, and cultural rigor. Indigenous methodologies means that we look to incorporate in our methods and work the strengths and resiliency of our people and communities, to incorporate and measure the impacts of cultural activities and ceremonies. How does family community affect health outcomes, behaviors, and opportunities? We just don't highlight disparities, but focus on strength and resiliency of our community, of our people. Indigenous epidemiology is applying traditional knowledge for strength-based analysis of Indigenous data. Our analysis is done with the intent to also assess the positive outcomes and supplement our findings with stories and qualitative data and understanding the strengths of small number analysis. We must acknowledge that just because Western methodologies may say statistically that the difference between two outcomes is not significant, does not necessarily mean a problem does not exist. Small number analysis may be the springboard that is needed to conduct additional and further surveillance and research on American Indian and Alaska Natives. Indigenous research, our research, is done for the love of our people and recognizes that we have always been scientists and researchers. It recognizes our strengths. This means looking at research in an Indigenous way. This is different from what we have been taught from a Western mindset. We must challenge the evidence-based practices that have been acknowledged and developed for the general population. Whose evidence is this anyways? Whose practices, interventions are these that we are implementing? Evidence-based practices should include our Indigenous and cultural activities. These activities, our activities, have been left out of research. Lastly, cultural rigor is being grounded in cultural knowledge and supplementing when needed with Western science, making sure we include to tell our stories and highlight strengths and not just deficit-based outcomes. So now that we have an understanding of data sovereignty, decolonizing data, and the principles that guide these practices and why it's important, I want to talk to you about data challenges regarding American Indian Alaska Native population and how these challenges are prevalent in the underestimation of morbidities and mortalities of Indigenous people. Understanding these challenges is essential to understanding why we need to implement and practice data sovereignty. This slide shows various data challenges we often see when collecting and analyzing data on American Indian Alaska Natives. In a research, policy, and societal context where epidemiological evidence and data are critically important, we work to provide accurate, actionable data, but have some unique considerations and challenges when we assess Indigenous populations. Laid out here are some of the challenges of conducting epidemiological surveillance and research in Indian communities. These challenges overlap and interrelate and have very real impacts on our understanding of Native communities and their health risks, behavior, strength, and patterns of resource allocation. In the next few slides, we will discuss these data challenges, their impacts on the health and well-being of American Indian Alaska Natives, and then discuss how to address these challenges. First, looking at lack of data. American Indian and Alaska Native are a small population. There are approximately about 5.5 million American Indian Alaska Natives, which is roughly about 1.7 of the estimated total population. The population isn't that large to begin with, and the more granular you get in terms of stratification for health outcomes, demographics, and geography, the fewer people you have to work with to record meaningful data. So how do we correct this and increase the sample size? Well, there should be an inclusive standard and accepted definition of American Indian Alaska Native. Inclusivity pertains to those who identify as American Indian Alaska Native alone or in combination with another race, and should also include those who identify as Hispanic. When possible, consider aggregating data over time or expanding the geography being studied, such as including a few neighboring counties. While looking at data by sex, race, and age is more telling, it may be important to limit stratification in analysis for already small population in order to keep the sample size as large as possible. Because it is a small population, there may appear to be a statistically significant difference, but even a small difference could indicate an area that should be further explored. Limited available data sources are another reason for lack of data. Particular to the work of UIHI is the lack of data sources that collect both race, ethnicity data, and geographic data, which greatly confounds the ability to conduct research specific to the health of natives. States and national health departments won't provide data that is more granular than state level, which obscures variability in population health linked to geographic context. In order to address limited sources, there should be a mandate on the collection of race and ethnicity in health data that utilizes local, state, federal, and territorial funds. A limit should be imposed to stratification and analysis that reduces the sample size. Though it is understandable that resources are often limited, creating a supplemental report specific to American Indian Alaska Natives should be considered. Challenges of westernized systems also create data challenges for American Indian Alaska Native populations. For instance, the biomedical epidemiological method. This model guides the federally funded research paradigm in the United States and requires researchers to justify the need for a study based upon evidence-based practices and westernized paradigms that often are insufficient to understand the health status and well-being of Indigenous communities. As I said before, so when we talk about evidence-based practices, the question that comes to mind is, whose evidence are we talking about? And is it Indigenous evidence-based practices? To address this, we should conduct mixed methods research, use both quantitative and qualitative methods that include storytelling, focus groups, and key informant interviews. This is vital, important, and effective approach to assess the health and well-being of Indigenous people. Another challenge we see is the lack of cultural relevance with data collection tools in westernized systems. Most data collection tools are not culturally adapted and do not ask questions that hold resonance for Native communities, and thus the results cannot fully inform policy and programs in Native communities. To correct this, we must place Indigenous voices and knowledge at the center of the epidemiological evaluation and research process. We must insist Western tools be culturally adapted. We must use tools, models that include Indigenous health equity, collaborate with Native communities and tribal leadership, and allow for them to determine their needs and their priorities. Another challenge is collapsing racial data into other. This creates invisibility and erasure. Collapsing racial data into other or into a multiracial category frequently makes American Indian Alaska Natives invisible. Too often in the publication and presentation of data, racial groups with small numbers are collapsed into a catch-all other category that renders invisible and unique data of the unique data of each group. Additionally, with growth and recognition of multiracial individuals, data collection is increasingly allowing for individuals to identify with more than one race, which is tremendously important. However, those individuals are homogenized when their race is reported out simply as multiracial. American Indian Alaska Native is a fast-growing multiracial group, and when we combine American Indians, Alaska Natives into other category or two or more category, this tells Indigenous people that they are not important, they are insignificant, or they do not matter. To address this, avoid reporting data collected and findings from analysis as multiracial or other. Consider oversampling American Indian Alaska Native population. And when collecting data or creating a data tool, allow for American Indians and Alaska Natives to identify as multiple race. Another challenge that created invisibility and erasure is suppression of small numbers. It is standard epidemiological practice to suppress small numbers out of concern for protective health information, and because small samples often yield statistically insignificant results, and when applied without question or consideration of alternative strategy, it is yet another form of erasure leading to invisibility of Indigenous people. As has been stated as solutions to previous challenges, ways to address this include limiting stratification to restrict the reduction of the sample size, considered aggregating data across time or geography, such as neighboring counties, and oversample the American Indian Alaska Native population. Another challenge we face with regards to American Indian Alaska Natives is the variability in the collection, analysis, and presentation of data. We see a wide range of methodologies that create an inconsistency in data available. For instance, how is American Indian Alaska Native defined? As alone or in combination with other races? How is race identified? As self-identification, as enumerated in the US Census, or tribal enrollment, which the Indian Health Service and other federal agencies use? There needs to be a greater transparency and documentation about methodologies and greater exploration of the implications of these choices. To address, we must conduct specific research on American Indian Alaska Native populations and communities where Native communities define how they want to be enumerated and identified and decide on topics that are relevant to them. Report limitations of work. It is important to list, explain, and discuss limitations in any analysis or research projects so those considerations can be accounted for in evaluating the results and outcomes, but also so that future endeavors may seek to address and improve upon these limitations. Look at the inclusivity of the definition of American Indian Alaska Native and clearly state definitions and collection strategies in your methodology. Other challenges of incomplete data systems specific to American Indian Alaska Native data are high rates of missing data in both race and ethnicity and health-related fields of data sets. It is hard to assess the health and well-being of a population if the information is not available. Of note, we most recently have experienced this with the COVID-19 data. To address this, there should be a regular assessment of the data collection process to identify problems and initiate quality improvement activities, mandate the collection of race and ethnicity and health data, and staff should be trained in the best practice to collect race and ethnicity. So now I would like to concentrate on racial misclassification, as it is a prevalent framework in the underestimation of the actual American Indian Alaska Native population. Racial misclassification is the practice of assigning other races to American Indian Alaska Native people such that they are not recorded as Indigenous. For nearly 50 years, racial misclassification among American Indian Alaska Native in data has been well documented. Racial misclassification has been investigated in death certificates, including all-cause mortality, varying specific causes of mortality, and infant mortality. Additionally, cancer surveillance, hospital discharge data systems, HIV/AIDS reporting systems, and STD/STI surveillance systems have all been identified as having racial misclassification data. There are many mechanisms by which racial misclassification comes about, and I would like to discuss several here. For instance, federal and state policies have either determined that a tribe is not federally or state recognized, excluding them from formal recognition, federal counts, and resources, or at certain points rescinded recognition, thus identifying them as a not recognized tribe. Just because a tribe is formally recognized does not change the identity of those members as Indigenous people, but it does alter their access to resources. Another reason for misclassification is the use of Spanish surnames to determine race. Particularly in California and in the Southwest, we see ethnicity enumerated solely as a basis of a Spanish last name. Another reason is self-identification with multiple races. As of the 2010 census, just under 45% of American Indian Alaska Natives self-identified as in combination with another race or ethnicity. While the census is designed to enumerate and capture this information, many other data collection tools only have the dimensions to capture a single race identity. Another reason is changes in tribal enrollment policy. Each tribe has the authority to establish tribal enrollment policies and standards, and to also change them, which can shrink or expand formal tribal roles and may cause confusion. Another reason, American Indians may not be a response category in medical records. Some data collection and input tools just don't have American Indian Alaska Native as a response category. Just recently, UIHI was doing some work in South Carolina, where we were reviewing data sets where American Indian Alaska Natives were combined with the Asian Pacific Islander population. We were unable to disaggregate the data to determine how many American Indian Alaska Natives were in this data set. Another reason, inconsistent definitions of American Indian Alaska Natives. Different data sources have different definitions. Another reason, imprecise definitions of American Indian Alaska Native. Some sources use self-identification while others use tribal enrollment. Another reason is a person changing self-identification. Racial and ethnic identity is an intensely personal thing, and people have the right to evolve in their self-identification. Another reason is tribes not federally recognized. At present, 573 tribes are federally recognized. More are recognized at a state level, and an untold number that have been excluded from formal recognition, which renders their citizens excluded from federal counts and resources. We see this in Seattle with the Duwamish. Next, racism. Some people are afraid to ask directly about race, or don't think that racial differences are important to capture, or American Indian Alaska Natives fear of being treated differently, therefore they may identify as another race. Lastly, subjective observation of the data collector. Particularly for mortality, there are instances of racial misclassification that arise from the subjective observation of a coroner or a medical examiner. So what does this all mean? Federally funded research is guided by the biomedical epidemiological model, as I've stated. Researchers have to provide justification based on evidence of population health status through incidence and mortality rates in order to be funded for research. Because of misclassification, many Americans, Alaska Natives are not found in the data. This contributes to the problem of small numbers. When data is limited or misclassified, we see inaccuracy in characterizing health disparities caused by underestimating American Indian Alaska Native morbidity and mortality. Therefore, we believe there is no disparity or inequity. Because of this misrepresentation, we then think the issue being investigated is not as prevalent in the population as we may have thought. This defines the mindset regarding the health and well-being of the population. This then affects funding. A lack of funding ultimately leads to more erasure, causing distress of being perceived as not important, which at the heart of all of this further threatens and impairs the health and well-being of our American Indian Alaska Native communities. While correcting for racial misclassification is important, we know that prevention of racial misclassification would be ideal. For example, there are instances where when racial misclassification in data is identified, but states either do not correct or may take several years to correct. By that time, researchers have moved on to more recent data. So how do we correct and address racial misclassification? One strategy is to conduct specific research on American Indian Alaska Native populations and communities. We should work with the Native communities to understand how they want to be enumerated and identified, and to identify topics that are relevant to them. Another avenue would be to support linkage projects. This type of project compares public health data sets with tribal enrollment lists to identify cases of racial misclassification and then correct the counts. We will see some examples in the following slides. It is also important to report limitations of work. We must list and discuss limitations in any research project so that those considerations can be accounted for in evaluating the results and outcomes, but also that future endeavors may seek to address and improve upon these limitations. Lastly, there must be regular assessments of the data collection process to identify problems and to initiate quality improvement activities. It is also wise to train staff to properly collect racial and ethnic information. So I want to talk to you, here's a couple of examples of the results of racial misclassification and how racial misclassification can impact how we think about health, the health and well-being of Indigenous populations. This can also impact the amount of resources that go based off of the amount of resources that go to the population based off of this, this misclassification. So through the years, throughout the years in Oklahoma, they've participated in various IHS linkage projects. Here's one that was conducted. The data sources there below on this graph here. These linkages have looked at STD surveillance, cancer surveillance, and mortality. So here's an example from a publication in 2019 that were in Oklahoma. It was explored mortality rates from 1991 to 2015. And what we found, or what was found, I should say, by the researchers, not me, I didn't do this, but from 2011 to 2015, before the IHS linkage, the age-adjusted mortality rate for American Indian Alaska Natives was approximately 1,008 per 100,000. After this linkage was concluded, the age-adjusted mortality rate among American Indian Alaska Natives increased to approximately 1,305 per 100,000. Through this project that was conducted, they were able to identify approximately 4,000 American Indian Alaskan Natives who had been classified as another race during this time frame. What we saw here was an increase in the age-adjusted mortality rate of about 30% between before the linkage project and after the linkage project. Here's another example. This was done by our friends down in Northwest Tribal Epidemiology Center. The program is Improving Data and Enhancing Access in the Northwest. What they were doing is looking at mortality rates with regards to opioids. And what we see is that the mortality rate before the linkage was 19.6 for American Indian Alaska Natives. After the linkage was conducted, the mortality rate for opioids increased to 27.5. What we see is an increase of about 40% in the mortality rate here. This is another linkage project that was done by the Northwest Tribal Epidemiology Center, the Improving Data and Enhancing Access Northwest. This is looking at age-adjusted hospitalization discharges for the state of Washington in 2011. So what you see here is prior to the beginning of the linkage, or prior to the linkage, the age-adjusted discharge hospitalization was 8,290 per 100,000. After the linkage was conducted, you see that the discharge rate for American Indian Alaska Natives in the state of Washington in 2011 was 11,079 per 100,000. This was an increase of approximately 34%. So here's another example of showing data, the level of missing data and the impact that it has on our ability to make decisions or assess data, identify the needs of the community. At UIHI, we have access to CDC surveillance data for COVID-19. This is data looking at the amount of racial data that is collected, or the lack of racial data that is collected by each state with regards to COVID-19. So what we did was we looked at, these are states in which we've identified urban Indian health programs are located in. And we wanted to identify the impact of COVID-19 in these states and in the individual urban areas or metropolitan areas in these states. What we found was that of all the states that we have data for where urban American Indian organizations are, there's 27 of those states. Only 12 states had enough data that was collected on race and ethnicity. Our cutoff was the 70% had about approximately 70% or more racial data. So they were able to identify races in the data that was collected. So of those 27 states, only 12 states had enough data for us to make any assessment about what was happening among American Indian Alaska Natives in those states. So this is another, it's very difficult to determine what impact COVID-19 has if data is limited or it's missing, and racial data is not being collected. This graph just shows us the over the pandemic, going back from the very beginning of 2020 to most recently in 2021. We update this on a weekly basis. Is the level of racial data that is collected. So the completeness of racial data that is collected on the CDC data that states give with regards to COVID-19. And you see that approximately, it maintains at about 50%, and then it's gone down to about 40%. And then just in February, where we started to see a spike, the racial data was substantially missing from a lot of the data sets. I do want to say that there's a lag of about 2 weeks in which data is updated, the amount of data that is collected. So this will increase, but what we're seeing is that with regards to racial data, about 50% of the data has racial information, whereas the other 50% is lacking. So many states, many counties do not supply the racial data, so it's difficult for us to assess, again, the impact of COVID-19 on American Indian Alaskan Natives. So in response to the COVID-19, UIHI created a guide that includes recommendations for best practices for American Indian and Alaskan Native data collection processes. In the previous slides, we explored some of the urban American Indian data challenges and applied recommendations from this guide on how to address these challenges. Here's the link here. You go on to our website, you can download this document that identifies best practices on how to collect data on American Indian Alaskan Natives, and also how to do small number analysis. And so I just want to talk briefly, we talked a lot about already these recommendations for improving collection and reporting of race and ethnicity, but just want to review them again. So what we have here is one of the things that we strongly believe is that for those organizations, whether it be a state, local, private, nonprofit, universities, that we should mandate to collect race and ethnicity in health data that utilizes local, state, or federal and territorial funds. We should, as I've stated before, develop and use standardized definitions for American Indian Alaskan Natives. Many times we find that different data sources, different organizations, entities define American Indian Alaskan Native differently. Data tools should be used to collect race and ethnicity, and should allow for selection of multiple races with the ability to disaggregate the data once collected. Many times what we have identified in data sources is that people have the ability to select 2 or more races, but then they are placed into a strata of just 2 or more, and we're not able to disaggregate that particular strata. And so people, American Indian Alaskan Native, are a population that is more likely to identify with 2 or more races. And if they're put into that strata and we have the inability to disaggregate, then we really don't know what is actually happening with that population. So we have to have the ability to disaggregate this data. We also stress that we do not release tribally specific data without a data use agreement from the tribe that grants such a release. It's important that that information is actually reviewed by tribes, and a data sharing agreement should be established. What we talk to with state organizations or local health jurisdictions or any entity that is doing work with American Indian Alaskan Natives is not to report out any tribal information without the consent of the tribe. It is, again, we're talking about data sovereignty. It is the right of the tribes to have this information, to know what is being reported on them, and to make that decision whether or not that information should be reported. Another thing that we recommend is aggregate data on American Indian Alaskan Native populations. This could be meaning aggregate over several different years. It could mean that to aggregate different areas counties that are close to one another, geographical areas. This is to increase the sample size. Many times what we find is that there's not enough data simply by just looking at one particular year. We should always weight sampling of American Indian, Alaska Native. This is another way to address the lack of data for American Indian, Alaska Native. We should limit our stratifications in our analysis to restrict any type of reduction of the sample size, and avoid reporting data collected and findings from analysis as multiracial or other when possible. Other recommendations for improving the collection and reporting of race and ethnicity: link data sets to correct for racial misclassification. We should oversample, as I've said before. We conduct mixed methods research, both quantitative and qualitative. It's really important that both of these types of methodologies are conducted to understand the health and well-being of American Indian, Alaska Native communities. We should always report our limitations of data that is collected in our analysis. Public health medical personnel need to receive training on how to ask about race and ethnicity in a culturally attuned manner. Regular feedback should be provided to public health, medical, funeral homes, medical examiners, and coroners personnel about missing race data, along with a plan for quality improvement as problems are noted, and how to improve on collecting this data. Tribal epidemiology centers are established public health authorities and should be granted access to data that states and the federal government are collecting. We should also be approached on how to collect this information and how to analyze this information. We have a better understanding on how to analyze this information, how to present this information. And lastly is that funeral homes, medical examiners, and coroners must ask the next of kin or informant how the descendant would have described their race or ethnicity and tribal affiliation, and should abstain from placing information on death certificate based on a subjective observation. The Urban Indian Health Institute is excited to be working in this area, and as we encourage others to advocate on how data is collected. We also work to collect culturally relevant information, conduct mixed methods research, recognize that non-statistically significant does not mean a true difference does not exist. And it's important that we report strength-based results. So that concludes my presentation on the Indigenous data sovereignty in Indian country. And at this time, I'll entertain some questions. I'm not sure how much time we have.
We have until 11:45, so we're good.
I don't have a clock with me, so I have no idea what time it is.
It's currently 11:32, so we have about,
okay.
Yeah, 15 minutes. We have one question in the chat. Emma asks, do you know of any resources or trainings for healthcare, public health staff on how to collect race and ethnicity data?
Actually, I do. At UIHI, we are actually doing these trainings for several state health departments and also for local health jurisdictions. We've also been approached by prosecuting attorney's office for various counties throughout the US. We have developed several different types of trainings. Some are just an hour type of trainings, other are days, and we have one that's a 3-day training as well, where it's really interactive, and we have exercises that we do with those who attend the training. I think this is something that's relatively, I want to say relatively new in the sense of working with state health departments or local health jurisdictions. We certainly, and I think I'm speaking to the choir for those individuals who work in this field, working with ethnic minority populations, not just Indigenous populations, but any ethnic minority populations. We see this a lot, we experience this a lot, this is something I think that we have, it's been a challenge in the work that we are doing, and try to address this and correct for it. At UIHI, we decided that this was happening more often than not, that we decided that we would put together a training. So we do have one, and you can certainly reach out to me. I can provide you the resources. We're more than happy to share the resources that we have developed.
Have you all been able to develop any trainings for students, like epidemiology students, have been able to work with any?
Yeah. So I occasionally will do guest lecture, maybe like once, twice a year at various universities. They will invite me to come and do, this is within School of Public Health, but they have asked me to do presentations. So I have gone out and do this type of training to introduce to public health students. We also have internship programs at our organizations where part of the internship is sitting down. They go through this type of presentation, this training with us, and they also work with the epidemiologist specifically, so they get a better understanding of real world experience and what this means and the impact that this has on the health and well-being of American Indian Alaska Natives, and also on how to on the impact that we see with funding resources and how this impacts the development of programs, interventions, and so yes, to answer your question, we have training specifically for students. Like I said, I've gone out to do guest lecturing at various universities on this specific topic. I'll be more than happy to share the slides as well with anybody who's interested. I believe everyone has my contact information as well.
In the chat, Kelly just asked, do you have resources or trainings for doing research with tribes, particularly respectful Indigenous processes, approvals, ethics, and IRB processes?
Yeah, Kelly, if you actually, the resource that I identified, best practices, there's some information in there that's specific on working with tribes. There's recommendations in there. We also have another resource. It's not in this particular document that I referenced, but if you go onto our websites, there are some resources with regards to IRB processes as well. I believe Dr. Rose James will be presenting later this week. I don't know the date she's going to be. She's oversees our evaluation and research at our organization. And her area is IRBs and working with tribes and Indigenous populations. And I believe she'll be talking about that too. I just, one of the things I will say is I think it's really important that we understand data sovereignty and its application and how it's used and how we should really champion this and insist that data sovereignty be something that is understood, not just, I think Indigenous organizations, tribal epidemiology centers, tribes, urban programs understand this. I think the challenge is to get our state health departments, local health jurisdictions, universities, other public health entities understand and comprehend this and understand and comprehend the impacts of when we don't practice this. I think many times we have been left out on the side and have either just been omitted from reports where interventions, programs have been developed with us not being on the minds of how this would impact tribal organizations, tribal nations, Indigenous peoples. And many times there's just this assumption that whatever has been developed could be applied to tribal populations. And that's not the case. And so I think it's important for like when I've done work with, say, various state health departments, this is something that we discuss all the time. We discuss it very early on in our collaboration with them. So they have an understanding of where we're coming from and why this is important. And this is why we do the work that we do. And this is how we do it. So, I just encourage people to read more about this. Certainly go onto our website, look at the resources that we have. Anybody who wants to reach out and have a further discussion about this, I'd be more than happy to. It's hard to get all of this in an hour, and there's a lot of other information that I'd love to discuss. But like I said, we only have an hour to do this. But I appreciate you guys giving this opportunity for us to introduce this and to talk about it.